Thank you for joining us today. Today we're going to hear from David Mortimer. He is director of the Hospital Sisters of St. Francis Foundation Innovation Institute for Hospital Sisters Health System. And we're going to talk about the Illinois Telehealth Network collaborations and planning to increase access to care. The network is comprised of, the HSHS health system is comprised of 13 hospitals and an integrated physician network across Illinois and Wisconsin. David also currently serves as the Illinois Telehealth Network Administrative Director, and he's going to share an update on the network's latest collaborative planning and telehealth pilots in Central and Southern Illinois and their work that they've recently done to develop a formal governance board. David?
Thank you, Becky. Thank you very much for the invitation to speak on the webinar too. And I just wanted to double check with everybody, does my sound level okay? Okay, yeah, I see a nod from Becky, that's good.
Also, I wanted to let people know if you use your mouse button to scroll across the bottom of the screen, there's a Q&A, and that's going to be the best way to connect with David or I. You can ask questions throughout. We'll answer some throughout, and some will hold off till the end.
All right, thank you, Becky. And Becky, if you happen to see one of those questions pop up, feel free to interrupt me if I don't happen to see it in Zoom as I'm looking at the slide view. But I definitely want to welcome questions as we go through the slides, so feel free to interrupt. And I'd like to welcome you, and my name is Becky stated is David Mortimer, and I work with Hospital Sisters Health System, and I've had the privilege of being a part of the Illinois Telehealth Network. It's an emerging network, and I'm going to tell you a little bit about how it began and some of the needs that led to this network planning. And so some of you out there are perhaps part of mature networks with organization and bylaws, governance, a board perhaps, and we are a network in the beginning stages of planning. We are an emerging network, just in the process of finalizing bylaws and in the process of electing a board. What I wanted to share is just how this network advances the three aims of better health care, and lower costs. And what led to our network was the problem of silos. And for anybody in healthcare of any kind, rural healthcare, it's something that we encounter every day. Silos within organizations, silos within health systems, silos within, even agencies and institutions of our state and federal government. And the challenge is communicating with each other and planning together to solve problems collaboratively. And the problem of silos is something that a network is often something that helps solve. And for example, I happen to live in Wisconsin, in western Wisconsin, and we have up in my area of western Wisconsin a community area network, or what is called a CAN. And this community area network is actually based with a fiber optic infrastructure underground and a wireless infrastructure above the ground. And this includes hospitals, includes anchor institutions that are involved in healthcare and education. It even includes libraries and municipalities. And this is kind of a schematic of what a network looks like that's called a community area network. This is something that is a mature network in western Wisconsin, and we saw a lot of ideas come out of this network that was a fiber optic network that represented kind of a condo association where everybody shared and collaborated on projects. And we thought, well, can we use some of the experiences of this mature network to create a telehealth network? And for example, in western Wisconsin, the members of this community area network began with some schools, education, and a city county, and then kind of grew and added more members, got a federal grant and got a second federal grant, was part of a $32 million stimulus grant to build out the network across Wisconsin. And in 2011 became an unincorporated association, so it had bylaws governance in place. And members today are in the 30s, including a lot of different healthcare. And this kind of network has been able to solve problems collaboratively. And here's a picture of the first executive committee. And Becky, the reason I included this photo is this was the result of the first election when this network became formalized. And it's rather interesting. You can see that this picture was taken at one of my hospitals in western Wisconsin, and you see St. Francis photobombing the group in the background. Two people down in the back row is me with Hospital Sisters Health System, and the person next to me on this executive committee is from Mayo Health, and our system and Mayo Health are fierce competitors in healthcare. But in the network, we are fierce collaborators, and it's really interesting how competitors in a network can collaborate and create economies of scale that can help patients and help expand services, particularly to rural areas. The key benefits of a network, of course, are doing more with less or pooling resources. You got substantial savings that can be created by sharing costs, providing more or providing better services, particularly in rural areas. And you create economies of scale by sharing applications and services. Perhaps you're sharing staff or equipment. One interesting way that networks solve a lot of solutions is leveraging funding together, pooling resources together. For example, if there's a grant opportunity, you have a bunch of stakeholders that are working together that perhaps can come up with a match, a necessary match, in order to leverage federal or state dollars. Also, if you're working with a vendor, it's rather interesting to see when rural hospitals can collaborate together, providing higher volumes of patients that need certain telehealth or telemedicine care. By having higher volumes of patients, you can get better price points from vendors sometimes. And the theory, excuse me, the theory behind this comes from Eleanor Ostrom. And I put this slide in because if you're interested in her book, Governing the Commons, she describes this idea of folks collaborating together to take common pool resources, for example, like telemedicine, and using it together, not in a competitive way, but in where you have solutions that come together and have an approach where you design durable, collaborative, or cooperative institutions that are organized and governed by the resource users themselves. So this isn't a centralized government solution. It's not a privatization solution, but it's a collaborative type of solution. And Eleanor Ostrom, 2009 Nobel laureate in economic studies, the late Ostrom, this is her book, Governing the Commons. When we began with our telehealth network in Illinois, my first contact was to Becky, our Upper Midwest Telehealth Resource Center, and this shows the different resource centers. We wanted to do plan a network in Illinois, and I tell you, everything we began learning, our first stop was the website for the Upper Telehealth Resource Center. And this website introduced us to different networking resources and tools, and come to find out that there's a whole area of studies in networks, particularly telehealth networks and rural health networks, and an organization and books and publications. And the Upper Midwest Telehealth Resource Center the website was a wealth of information, a wonderful starting place for us. Gregory Blanc, in Principles of Rural Health Network Development and Management, this is a publication that's online, ran across it through Becky's website. This is a quote that kind of summarizes that collaborative strategy. Rural health networking is a collaborative strategy. It requires individual actors to come together voluntarily, agree on a course of action, and take action cooperatively. And it requires time, trust, will, and skills. And I think this quote summarizes very well the idea of what a network can mean to rural health and expanding access to care in rural areas, underserved areas, because sometimes it's not the barrier of funding or even equipment. Sometimes the barrier is going back to those silos, being able to break down those silos by getting people around the table and planning and discussing and even sharing needs. The key elements of network development, you have to identify a compelling need together as a group sitting around the table. Then you can start talking about expected benefits that result from collaboration. And then you can start planning where form follows function, and you can, that form is determined by network functions. And then you have the chance to begin talking about and discussing the key participants and solutions. Sometimes the solutions happen to be right around the table. Sometimes it's an outside stakeholder that needs to be invited to the table, or sometimes it's a vendor that, you know, perhaps we don't even know about yet. And so you have an example of this with our network, where we kind of looked at the compelling need, expected benefits, and then how form and functions and participants address those needs. This is on one page, kind of our case statement for telestroke in rural areas in Illinois. The compelling need, we brainstormed what was the compelling need in the community, the compelling need for our emerging new network, and then the expected benefits for the community, benefits for the network, and then the form, the functions, and the participants. We began with our network by creating an MOU. We wanted to get folks together, stakeholders, mostly rural hospitals in Illinois. So we created an MOU. We found some federal HRSA funding that would provide funding for network planning. And this MOU began with 16 members, 16 CEOs, mostly rural hospitals, that signed in our second year of funding a HRSA Rural Health Planning Grant. We have a MOU that has participants that are number 21 CEOs. And beginning next year, we've expanded the MOU to 23 members. So the MOU just kind of lays out, it's not a legal document, but it's a document that just shows that what the purpose of our network is, what we want to do in coming together to plan, and what kind of planning we anticipate doing. So we started with 16 members in 2014. We added a 17th member, another rural hospital. 2015, we have 21 members. And because of a rural hospital going with another health system and another hospital closing down, we lost our first 2 members. So currently, as of today, we're at 19 members. And then beginning in June next year, we will have 23 members, adding 4 more members to our network. And of course, this is a network to do planning together, to sit down, to be around the table, to start planning out a telehealth network and solving those problems, doing that form follows function in the previous slide. So one of the things we had to do in our first year was to come up with a mission. And the mission of the Illinois Telehealth Network is it promotes the capacity of members to improve access to healthcare in rural, underserved, and disadvantaged communities through the application of telehealth and telemedicine solutions. Pretty straightforward. We're using telemedicine, telehealth, any kind, to increase access in rural areas. Very broad definition. We have a vision. The vision is to connect and share resources, strengthen rural health care, and save lives. This began, the saving lives part, which is the most exciting part and really keeps our momentum going, happened in our emerging telestroke program in the first year when we began having rural sites go live with in-touch equipment in the emergency departments and Eagle physicians, neuros providing neuro consult care with a response time between about 7 and 9 minutes, which was just stellar, just incredibly stellar. The goals of our network, we have 5 strategic network goals that we kind of laid out in our strategic plan about the network members will provide and share resources. They're going to collaborate on development of multiple telehealth services. We may go in different directions simultaneously, depending on where the need and the interest is with our members. And our network members will promote financial stability for the members' telehealth programs. And number 4, collaborate on disseminating CMS telehealth billing information. And this is where the Upper Midwest Telehealth Resource Center has been a tremendous educational help to our members. And lastly, the network will support the members' own local education, advocacy, communications, and marketing efforts. So designed to meet the needs of its members. So member benefits are collaborative support for telehealth service development, access to grant funding. We do a lot of different types of grants, opportunity for group purchasing, shared resources, and currently there's no member dues. That might happen someday as we get our bylaws are finalized and we're in the process of electing our first board, and someday down the road, there may be member dues once the network creates value to the members where they would be willing to participate. So our network planning, our focus areas, I mentioned telestroke. We've also been exploring in the emergency department's tele-intensive care consults. There's been some interest in tele-NICU, tele-peds. For some time, about 15 years, one of our hospital members, HSH's St. John's Hospital in Springfield, Illinois, has had a heart failure remote monitoring telehealth program. That's been something that has been post-acute. So after hospitalization, patients have this heart failure remote monitoring telescale. We've been expanding that into a post-acute setting, which I might have time to discuss a little bit later. Virtual care, telebehavioral health, telecardiology is something that we'll begin discussing in June, now that Prairie Cardiovascular will be joining our network. And this is a list of some of our accomplishments. The 5-year strategic plan was huge. That was funded by our generous HRSA grant in the first year. This kind of lists some of the things that we've accomplished. One thing that I've been involved in is our grant projects. When we have different rural hospitals, we've had 6 rural hospitals so far that were not able to participate in our telestroke program because they didn't have equipment in their emergency departments. And we were able to apply for 2 USDA distance and learning telemedicine grants 2 years in a row and get funding for equipment for those hospitals so that they could participate and continue participating in the network. So currently we have $1 million in active grants that are helping accelerate projects in our telehealth network. Very much there's many different levels of involvement. Some of our members might be attending meetings just to kind of keep an eye on things for opportunities. They might not be quite sure yet what kind of telehealth or telemedicine solutions might be best for them. So there might be a lower level of network involvement, or there might be a higher level of network involvement where a stakeholder, a member might be attending network meetings, but also involved in perhaps a committee or the governance committee, or actually working with a couple of other members to launch a new type of telehealth or telemedicine service to deploy it. This is our timeline. We began with a HRSA grant and then a second year of network planning HRSA grant. And this kind of shows you the growth and where our 5-year strategic plan, we hope that it will take us. This is our planning team. We have 5 members that are from Dr. Gurpreet Mander, who is the chair of the network, and Chris Schmidt, who is at HSHS St. John's Hospital, who oversees the Telestroke network. Patrick Nudo at St. Francis Litchfield, who is our finance director. And myself, I work with the Innovation Institute for Hospital Sisters Health System, and my area is currently the administrative director for the network, but I'm also a grants person with the foundation. So Julie Edwards is the outreach person, and this is our core team. But our team would not be able to do the work in helping the members plan the telehealth network without our advisors and technical assistants, which includes the Upper Midwest Telehealth Resource Center, also Illinois Hospital Association, and then with the Illinois Department of Public Health, the Center for Rural Health. They've been tremendously helpful. We've had consulting help from HMA in Chicago, and also a lot of resources on networking and technical assistance help from the National Rural Health Resource Center and Rural Health Innovations based in Duluth, Minnesota. We have currently 4 committees in our network, and these committees look at areas that have been determined by the members to be areas of interest or areas of need. And for example, the Telebehavioral Health Committee is actually meeting tomorrow, I believe, and will actually be talking about rolling out services, inpatient, outpatient, and ED services in some rural health hospitals, and that's very exciting. So we have 4 committees currently. The governance steering committee has just turned into a nomination committee to nominate, to oversee the nominations of people who could be elected to the board of the network. When we began, we were thinking a network was a pretty simple scenario, a hub spoke, but we've since learned it's actually quite complex with many different hubs, many different spokes, and then we've since discovered that when you, instead of providing hub services, you have a vendor involved, for example, for virtual urgent care or telepsychiatric services. You don't even have a hub anymore. Your vendor provides the services, and your network are the sites that bring those services to patients. So we've begun as a horizontal network where we've all been hospitals, rural, critical access, a couple of urban hospitals, and then we're starting to think that a vertical network might be the direction we'll be going, as we have a physician group that has become a member, and another physician group, Prairie Cardiovascular, becoming a member soon. So we're tending to become, we're going in the direction of becoming more of a vertical network. And once you open that door, there's a lot of possibilities, especially in local communities. And here's an example of a multiple hub model. And one of the ways that we've been able to accelerate progress, you know, it might take years and years for a network to work through with legal folks, bylaws and governance. We've been able to accelerate that progress quite a bit by getting some funding from HRSA for HRSA network planning, rural health network planning. And we have 185,000 awarded, 100,000 pending right now, and we hope to apply for a 3-year development grant. We received 2 USDA rural development grants. We've got a private foundation grant for our heart failure remote monitoring from the AstraZeneca Healthcare Foundation, their Connections for Cardiovascular Health, and then some matching funding from the Hospital Sisters of St. Francis Foundation, the Innovation Institute. And our strategy, we found that when in applying for grants, it always helps to be able to provide matching funding, and that really shows a serious application, and I think tends to be scored a little bit higher by reviewers. Elected representatives are very important in our network, keeping them up to date with what's been happening, keeping them in the loop with progress on grant projects, HRSA projects, USDA projects. And as you can see, one of the strategic strengths of our network is it includes many different congressional districts. And so we've been very involved in getting support from our 2 senators, Senator Durbin and Senator Kirk, every time we apply for a federal grant, and also our members of Congress, Congressman Shimkus and Congressman Davis. Here's examples of HRSA support letters for grants. Whenever we have a members meeting also, we reach out to our elected representatives and try to include them or invite them to speak to. And one of the strategic advantages when you get folks around the table representing many different rural hospitals, as you can see from the green in this member matrix table, this is from one of our grant applications, you start seeing a lot of capacity, a lot of attractive things for grant applications, because you start seeing that your members are serving very underserved areas, health professional shortage areas, mental health professional shortage areas, medically underserved areas, and rural areas or critical access hospitals. And this table just kind of demonstrates a lot of the attractiveness when you gather stakeholders like this together into a network and you begin applying for, say, a federal grant or a state grant or a private foundation grant funding. You have a lot to offer. And then when we have new members that join, some of those new members may not even realize the strength that they have when they gather, together collaboratively with other rural hospitals. And that turns out they bring a lot to the table to really strengthen a grant application. When they think, that they may not, alone, they might not qualify for so many things or even have the capacity on their own to apply for a federal grant, which is sometimes pretty involved. At our first meeting last June, our first annual meeting for our CEOs, we had 21 members in the room, and we awarded our first Pioneer Award, our Innovators Pioneer Award. It went to Hillsborough Area Hospital, a rural hospital, and that had deployed telestroke with our St. John's Hospital in Springfield, Illinois. And this is an award that was presented to recognize their hard work in getting it up and running. And Rex Brown, the CEO, and David Harrison, the CNO there, are receiving the award. The award is a picture. This is pretty amazing. Is a matted frame picture of this magazine that is from 1924, and it's an illustration in this radio magazine of what telemedicine could be. And this was a complete artistic fantasy because it wasn't until 1926, 2 years later, that even television was invented. So this shows the little device on top of this thing actually shows kind of something like light streaming down on this boy, which is capturing his image in video and transmitting it back to this doctor who's remotely examining him. So this was the first artist conception of what telemedicine could look like someday. So that was the Telemedicine Pioneer Award, which our network is giving away annually to one of our members. And again, this is our planning focus areas. And one of our focus areas is virtual urgent care, which has been really exciting, led by HSHS Medical Group, anytimecare.com. And it's really interesting how this has been deployed even amongst employees. For example, when I'm in Illinois, traveling or working as a HSHS employee, and not feeling well or something, I need an urgent care visit. My urgent care visit begins with an app on my iPhone that I can access anywhere, and I can get a visit within a few minutes. And if the physician that I'm visiting with through my iPhone can't help me in my first 3 minutes, my $29 is refunded to me, and they recommend I go to urgent care or an ED in person, or maybe a primary care physician if it's not urgent. And so that's been really exciting too. This kind of schematic shows how the virtual urgent care has been deployed. It started, I believe, last February in Illinois. And this is some of our technology that we've been using. We tend to use the definition of telehealth being remote monitoring. For example, in this case of our heart failure patients, using the CardioCom telescale. HSH's St. John's in Springfield was CardioCom's first customer 15 years ago when the company started up, and today CardioCom is owned by Medtronic. The equipment we use for telestroke and other ED care is in-touch remote presence light equipment, which you see on the right. And I have a couple of slides which I won't go into because I've reached the end of my time. These discuss the launching of what we call our teleheart pathway. And these are some slides that our network's advisor, Dr. Mark Stamfel with Prairie Cardiovascular and at HSHS St. John's, presented to the Illinois Hospital Association last November. They had a forum called Commitment to Transformation. They have this full slide deck online, but this just describes the heart failure remote monitoring program. And several years ago, we had some HRSA funding, 3 years of a telehealth network grant program that allowed us to have 844 patients and track them very carefully just to kind of measure the impact of this post-acute monitoring program on readmissions. Because as you know, heart failure readmissions is a really difficult and costly thing. The patients that we found in our 844 cohort had an all-cause 30-day unplanned readmission rate of 12.9%. That was stunning because that's compared to a 24.7 rate, which was the national average for the same period. And this is also stunning, but 94% of the patients in our group reported making changes in self-care. 97 reported increased symptom awareness, really demonstrating the educational component and the value to this telehealth program. And there again is a picture of the CardioCom scale and how the program engages patients with teachable moments. And when there's a red flag in the daily weight and the other information that is sent via telephone lines, landlines, or sometimes cell lines if they're in an area without a landline. A flag on a certain day will result in a phone call, a contact from a heart failure RN, at St. John's Hospital, and an engagement, talking about diet, what did you have last night? Was it salty? Perhaps a medication change, and those interventions and that education helps head off early on what could turn out to be an emergency room visit or another readmission. So these slides tell how the program started, how it works, how it recognizes problems early, how the teleheart pathway, the heart failure nurse intervenes, and then this program was expanded into rural and underserved areas with our TNGP HRSA grant, where we were able to take our program and involve and provide the service free to 20 different hospitals across Illinois, mostly rural, and this was just tremendous. This was another example of how a HRSA grant can accelerate the success of a program in mostly an urban area, but to reach out into those rural areas where people really have needs and really have less access to something like this. And of course, these are the outcomes that I mentioned that were pretty amazing from that group that included 844 patients. So the outcomes of better care and less cost. Another example of how telehealth and telemedicine can not only increase access, but provide better care at less cost. So, and we've been able to take this program and expand it into an outpatient setting. There was some thought amongst our cardiologists that were involved in this program that it would be beneficial to identify high risk and fragile heart failure patients even before they're admitted to the hospital, and to identify them in an outpatient setting, provide or offer this program to them, which is essentially educational, kind of like a boot camp for 3 months to really get a handle on their symptoms and use those teachable moments. And AstraZeneca Healthcare Foundation, the Connections for Cardiovascular Health, provided the startup funding to do this new pilot and test it in 13, we targeted 13 different cardiovascular clinic communities in Illinois. And that lists the program goals. And thank you very much. I'd be glad to entertain any questions that you have on the Illinois Telehealth Network or some of the different pilots that we've been exploring already. Or if you have any questions about what the network might be thinking with next steps or its governance and bylaws.
Thanks, David. I really appreciate it. You guys are just a wealth of information, and the questions are starting to come in. One, could you go back? There, you had one slide where you had the cardiocom scale, and then one of the hearts. I had a question come in about when a neurologist is using that functionality and using the video and the audio. So in this situation, there's always the interactive video conferencing going on, correct?
That's right. There's video. It's an average of about 17 minutes that each consult takes from beginning to end when they have the neuro specialist come into the emergency room and provide a consult. The average is about 17 minutes.
Okay, thank you very much. And then I haven't gotten the question yet, but I know I will. We are recording today for those of you that may not have joined right at the beginning, and we will post this recording out on the UMTRC's YouTube page, and I'll send out a notice when that recording is up. So our next question is, how do you handle documentation between the different network participants, particularly if they're not using the same EMR?
That's a very good question. And in fact, since I'm on this slide, and since we were discussing telestroke, the equipment that you see on the right-hand side is an InTouch remote presence light. It's kind of the cheaper version. You see much more expensive versions of different vendors too, and this particular model has flexibility to work with Meditech EMR, with Epic EMR, or many other types of EMR, and it basically uses the old kind of PDF or fax machine kind of system where it takes the visit information and it gets it into the EMR in a pretty simple way. And we've been impressed with this particular model because, as you know, our network includes many HSHS, Hospital Sisters Health System hospitals, which have all the same EMR. But it also has many other rural hospitals that are a part of the telestroke network, and they might have various different EMRs. And so we needed a type of vendor and equipment that could talk to and work with and those various EMRs. And another thing that we learned too in working with rural partner hospitals, sometimes in those rural areas, the connectivity, just the basic broadband connectivity, wasn't that great sometimes. And this piece of equipment turned out to work pretty well for us because it is a vendor that's able to compress bandwidth and adjust latencies so that you don't have that problem, which is sometimes an issue in rural areas of where your bandwidth drops or fluctuates, and you have variations in bandwidth capacity. You don't want to break up in service or an audio miss or an audio visual miss when you're in the middle of a neuro consult with a stroke patient or a stroke patient's family or member or other ED physicians or staff right there in the room. You want the clearest picture, the best audio possible. And this particular piece of equipment has been pretty successful in some of those rural areas. There's some rural hospitals that are still using copper to connect to the internet in Illinois and in Wisconsin too. But that copper was laid probably 100 years ago, possibly. But the connection through is not a fiber optic connection sometimes, and having a connection, being able to use equipment that can deliver, as you kind of imagine the internet as a freeway, and once you get out there and your signal has to compete with other traffic, if it's a certain time of day when everybody's using their Netflix, that's going to create congestion. And this piece of equipment we found was very successful to be able to handle that bandwidth changes.
Thank you very much, David. We have a comment. Thank you for the wonderful presentation. It was very informative. And a follow-up question. They'd like to know what your experience has been with behavioral health issues that have affected the network. Are the member hospitals equipped with proper resources and software to overcome these solutions?
That's another great question. And in fact, because of that exact question, the first thing we did in our first 3 months of organizing our network was to do a needs assessment. And you have to imagine, the folks we have around the table, some of those stakeholders, some of our network members are actually competitors. And so we really needed a level of trust. We had an outside consultant to be able to look at the responses so that it wasn't something that people felt like they had to be guarded about their sharing their problems or their needs. So we did this not anonymous, but we did this survey, needs assessment survey, to really drill down into what needs do you have in your emergency departments, for example, that perhaps telemedicine or telehealth could help. And the response was was amazing. And in fact, when we started out and when we designed the questions, it didn't really occur to us to drill down into behavioral health. And then some of the responses where you could fill in other and add a narrative of some problems that weren't in the yes/no questions or fill in the blank questions. The response that we got that we didn't anticipate was that the number 2 need of all of our network members had to do with behavioral health. And we learned very quickly that telepsychiatry was a way of addressing that need, because some of our ED hospitals with rural emergency departments had no psychiatrist at all, nobody on call. And a lot of them had problems where they'd have a telebehavioral health patient in an emergency department room that would be there for quite some time, taking out, they would not only be able to address the needs of that patient appropriately, or get them the help that they needed, but that patient was also taking up a room that somebody else needed. And so they had a problem with throughput just because of not having the necessary professionals in an area. Some we learned also through that needs assessment. Other hospitals were not having problems in their EDs, they were having problems in outpatient. There was no outpatient within many, many miles around that a patient could be referred to, no psychiatrist for follow-up care. And some hospitals had inpatient, ED, and outpatient needs for that telepsychiatry could help. And that led to the formation of a committee with 2 co-chairs representing hospitals that were very interested in deploying a telepsychiatry service. And that committee began to identify and interview different vendors, outside vendors, and actually settled on a vendor, and actually is beginning now to discuss the contracts for and pricing for inpatient, outpatient, and ED telepsychiatry. And it's interesting too that, again, by having rural hospital stakeholders around the table talking with each other, working together, we're able to get a higher volume of patients where that together, even though they're separate contracts, that together higher volume will get all of the stakeholders a better price point from the vendor.
Great, thank you. Another question and this is kind of specific to the slide we've still got up. Are the neurologists, what percentage of the time are they actually using a cart with the interactive audio video, or do they end up reverting back to the phone?
Nearly 100% using the in-touch audio visual. In fact, the neurophysicians that we use are from Eagle Physicians. Their response time has been so stellar in each of the spoke sites of 7 to 9 minutes when they're called for a consult, that the response time for HSH and St. John's started looking at that. And instead of being the hub provider of neurophysicians, it was decided that it would be, and also, very difficult sometimes and expensive to provide that 24/7 neuro care and coverage in emergency departments. St. John's itself decided to have Eagle Physicians provide that consult, that initial consult in the ED, just because it was so convenient, so fast for the patients, high patient satisfaction resulting. And also then you have your own neuro doctors who don't have to work 4th of July weekend and be on call. So it was a service that we began with the spoke sites, and then the hub was so impressed with that response time that the hub decided to do Eagle Physicians themselves too. And Eagle works exclusively through the InTouch equipment, so that there's approximately a 13-minute on average audiovisual consult and connection. The InTouch equipment allows that neurophysician to see any CT scans, labs through the same connection and make those decisions, so that there's faster decisions for stroke patients, because time is brain, and every minute counts. And also, it's been very helpful to be able to determine if a patient needs to be transferred to a higher level of care, that those decisions are made more quickly and the transfers become more appropriate, so that you don't get a transfer often that was erring on the side of caution, and once they got there, and they probably could have stayed back in that rural hospital. Rural hospitals really appreciate being able to care and keep and appropriately care for patients in their EDs.
Thank you very much. Let's see, let me go to, this is an interesting one. Do you have, and I'm going to ask, in way of answering this, I'm going to ask you again, did you have your contact information either on the first or the last slide?
Yes, they're actually on the first and the last slide. And I'll scale down here. There we go. I have my email address and phone number too, and feel free if you have questions or would like other information about our network.
Okay, because I think the answer to this question I'm going to go ahead and give you is to contact you directly. The question is, how can those of us in non-rural areas in Illinois help partner on legislative initiatives?
Yeah, that's a very good question too. On legislative initiatives, we have hospital associations, or like the Illinois Rural Health Association is really good. Illinois Hospital Association, we have critical access hospital groups in Illinois. Those are really helpful because they have experience and also that relationship with our elected representatives. And especially when reimbursement issues come up, they tend to be the go-to place, and the vehicle, or to have those tools for advocacy in place. And they're kind of our go-to organizations also for disseminating information. You know, when is the proper time to contact your elected representative, and is it you know, something that's so urgent that it's time to pick up the phone, or will an email suffice? And also they're great disseminators of information. So we're very fortunate in Illinois to have these organizations.
And another question, this one's about Wisconsin. What is the state of Wisconsin's take on the use of telebehavioral health when a patient needs inpatient psych? Is it acceptable for involuntary admission?
Another good question. In fact, compared to Illinois, Wisconsin is pretty much a blank slate legislatively and regulatorily. You know, there's different reimbursement issues, but as far as what you can do and how you can do it with telemedicine and telehealth, it's pretty much a blank slate. And in fact, just 2 months ago, our medical examining board, our MEB, took a model regulation from another state. I believe it might have been even Idaho or something, and proposed it for Wisconsin. And there was actually quite a response against that, because it created a lot of barriers to what hospitals and rural clinics and rural hospitals were already doing in Wisconsin, and would have resulted in a lot of barriers to increasing that access to care. And so Wisconsin's kind of in a place right now where they're reevaluating that MEV regulation and looking at a lot of other things, and perhaps deciding that a lot of the normal practice guidelines that they have in place now are pretty sufficient for the kind of care and the ethics of care and the quality of care that we might have all that we need in place now with just a few small tweaks around the edges for telemedicine and telehealth.
Very good, thank you. One other follow-up question. Somebody asked a question, I wasn't quite sure what they were asking, but I think you had a slide about becoming a vertical network. So what is the time frame, and what type of provider other than a hospital do you think would be added to the network next?
That's another good question. And in fact, it seems like our network is very open to the evolving into a different kind or a more diverse network, like a vertical network. It really depends on the local community. One example this might happen is if we have a local community that has psychiatric services or behavioral health services provided by a local nonprofit, it might make sense at some point in time where that entity, that nonprofit, might become a member, because it could be a very crucial player, a very crucial solution in what the network does as a whole to address issues that other members have in other rural areas. So it might organically kind of grow that way. We're not really certain, because we're just at the point as the Illinois Telehealth Network, ITN, of electing a board. And that would very much be a board decision or direction that a board will be giving our network someday.
Very good. Well, I don't have any other questions. So David, I want to thank you again so much for being willing to join us. And I apologize again for the technology snafus that we had at the beginning. So thank you so much. We'll get this recording up on our website or on our YouTube page within the next couple days and get that link out to everyone.
Thank you very much, Becky. And again, I can't tell you how much we appreciate all the tools and help and resources and speaking presentations to our network members. We honestly never even would have had a good start. The very first step was our call to you. So thank you so much for all that help and support.
You're very welcome. Thank you. You're too kind. Take care, everyone.